Hi, I'm Michael Watson. Thank you very much to the Congress for allowing me to present. I'll be presenting the effect of surgical approach on node harvest and robotic gastrectomy. All authors have no relevant disclosures. Lymphadenectomy at the time of robotic gastrectomy has been shown in multiple studies to improve tumor staging as well as having a therapeutic benefit. Data from the Dutch gastric cancer trial as well as data from SEER have shown that increasing numbers of lymph nodes harvested at the time of gastrectomy is associated with improved staging accuracy as well as improved patient survival. These data have been incorporated into the NCCN guidelines, which recommend a D2 lymphadenectomy for patients undergoing gastrectomy for gastric cancer. A D2 gastrectomy is a lymphadenectomy that includes the lymph nodes in stations 1 through 7, which would be the perigastric nodes and those from the omenta, as well as the D2 nodes, which are those on the common hepatic artery, the celiac axis, at the splenic hilum, on the splenic artery, and in the hepatoduodenal ligament. In open gastrectomy, an extensive D2 lymphadenectomy is associated with increased blood loss, morbidity, and length of stay. Therefore, while an open, extensive lymphadenectomy is associated with improved oncologic outcomes, it is also associated with increased short-term morbidity. Since the development of minimally invasive techniques, laparoscopic gastrectomy has been shown to have improved short-term outcomes compared to open gastrectomy. This includes shorter length of stay, decreased operative blood loss, less morbidity, and less mortality. Furthermore, robotic surgery is a minimally invasive approach with novel innovations such as articulating wrists on instruments, stereoscopic visualization, improved surgeon ergonomics, as well as the ability to use techniques such as ICG fluorescence for lymphatic mapping. Our institution is a high-volume tertiary referral center. We have transitioned from open surgery to more minimally invasive approaches with the increasing use of surgical robotics over the past 10 years. Currently, our group's preferred approach is robotic gastrectomy for patients with resectable gastric cancer. At the time of gastrectomy, our intent is a D2 lymphadenectomy. This is to leverage the short-term benefits of a minimally invasive approach, the ability to perform a meticulous lymph node dissection. The aim of this study was to evaluate the effect of surgical approach on total lymph node harvest and gastrectomy at our institution, the hypothesis being that robotic approach would be associated with a greater lymph node harvest. We studied patients undergoing gastrectomy for adenocarcinoma in a retrospective fashion from the years 2007 to 2018. The primary outcome was lymph node harvest. We also analyzed patient age, sex, race, BMI, year of surgery, neoadjuvant chemotherapy, and tumor pathologic T classification. We used a chi-square test for categorical variables and a Kruskal-Wallis test for continuous variables. We then performed a multivariable analysis using a multivariable Poisson model created with variables found to be significant from univariate analysis, as in those with a p-value less than 0.15. We then made pairwise comparisons with a least mean squares estimate. Comparing cohorts by surgical approach, we found significant differences between groups in BMI, such that patients undergoing robotic gastrectomy had a higher BMI. Additionally, we found differences in the use of neoadjuvant chemotherapy, with patients undergoing robotic gastrectomy having a higher incidence of the use of neoadjuvant chemotherapy. We also found significant differences between groups by the year of operation. We found that there was an increased use of robotic surgery over time. Comparing lymph node harvest between surgical approaches in a univariate fashion, we found that lymph node harvest was significantly different between groups. The median lymph node harvest for robotic gastrectomy was 36, compared to 17 and 16 for laparoscopic and open. On pairwise comparison, we found that robotic was associated with greater lymph node harvest than both open and laparoscopic, while laparoscopic and open were similar. We then performed a multivariable analysis to identify independent predictors of lymph node harvest in our cohort. We found that surgical approach was an independent predictor of lymph node harvest, We then performed pairwise comparisons between surgical approaches, found that robotic was associated with greater lymph node harvest than open and laparoscopic, while laparoscopic was associated with greater harvest than open. Additionally, we found that BMI was an independent predictor, such that patients with a higher BMI had a higher lymph node harvest. Found greater lymph node harvest for patients with male sex, greater lymph node harvest for patients with higher pathologic T classifications, and greater lymph node harvest for patients with later operations. In conclusion, robotic gastrectomy is associated with a greater lymph node harvest than both open and laparoscopic approaches at our institution. Furthermore, this difference persisted when controlling for confounding variables in our multivariable analysis. There are some limitations to this study. First, our institution is a high-volume tertiary referral center, so these data may not be fully generalizable to smaller centers. Additionally, we do not have long-term oncologic data, such as recurrence or survival. And lastly, there is selection bias between surgical approaches. The surgical approach was determined by a surgeon preference. Furthermore, there was an increasing use of the robotic platform over time, and while we used a multivariable analysis, they may represent a confounder that was not fully teased out of the model. Thank you very much, and I'll take any questions.